Hey there, fellow grad students. Test coming up on anxiety and insomnia? Well, I have 36 practice questions to get you ready for your upcoming test. Ready? Let's learn psych fast. Question 1. Which is the recommended time over which an anti-anxiety medication must be gradually tapered before discontinuation? Is it 1 week? B, 1 month? C, 6 months? Or D, 1 year? The answer is B, 1 month. Withdrawal from medication should be done under a health care provider's supervision. The withdrawal usually takes about 4 weeks, and it requires a gradual reduction in dosage and greater intervals between medication administrations. 1 week is just inadequate, and gosh, 6 months to a year, that's way too long, not necessary. Which one of these is the benzodiazepine of choice when treating anxiety associated with alcohol withdrawal? Is it A, chlordiazepam, B, oxazepam, C, diazepam, or D, clorazepate? The answer is B, oxazepam. So oxazepam and lorazepam, these two, they're drugs of choice for treating anxiety disorder because they have no active metabolite. Chlordiazepam and clorazepate are not drugs of choice when treating anxiety associated with alcohol withdrawal. You could use diazepam. Diazepam have not been studied as fully as azaspirone has been in treating these patients with that hepatic function impairment. Question 3. The outcome statement for a patient suffering from anxiety disorder reads, after 1 week on alprazolam therapy, patient will exhibit a manageable level of anxiety. Which assessment finding validates this outcome has been met? Is it A, patient is unable to participate in group therapy conversations? B, patient reports persistent fear about dying of a rare illness? C, patient verifies that family reunions trigger anxiety and excessive drinking? Or is it D, patient reports sleeping better and increased interest in activities? The answer is D. The patient's going to report sleeping better and have an increase in activities. The primary therapeutic outcome expected from benzodiazepine anti-anxiety agents is a decrease in the level of anxiety to a manageable level. So physical signs of anxiety have been decreased and coping skills improved. Being unable to participate in group therapy, having persistent fears, and choosing inappropriate coping mechanisms for non-catastrophic events indicate that anxiety is not manageable. Question 4. What would you caution a patient about when provided information about prescribing azaspirone antidepressant? A, risk for addiction. B, adverse effect of nausea. C, risk of injury when using machinery. Or D, the additive effects of CNS depression with alcohol. The answer is C, risk of injury when using machinery. So the most common adverse effect of azaspirone therapy is dizziness, nervousness, drowsiness, and lightheadedness. It doesn't really have a risk for abuse or addiction, but nausea and vomit are not common adverse effects. It does not affect the CNS, so no CNS depression, but it is recommended that they do not combine this medication with alcohol or sedatives. Question 5. Which patient is most likely to respond quickly to anti-anxiety therapy with benzodiazepines? Is it A, the patient with a history of long-term anxiety? B, the patient with recent anxiety reactions? C, patient with severe depression in addition to being anxious? And D, patient with incident of auditory hallucinations? The answer is B, patient with recent anxiety reactions. So patients with anxiety reactions to a recent event and those with a treatable medical illness that induces anxiety respond most readily to benzodiazepine therapy. For long-term anxiety, it's best to treat with medications such that are not a benzodiazepine, so like a prescription Zoloft, Paxil, Prozac, Effexor, Wellbutrin, those ones. However, if there's severe depression, it will not improve with the treatment of benzodiazepine. Also, patients who are having psychotic symptoms, they too will not respond to benzodiazepines. Question 6. Which two phases will make up normal sleep? Is it A, hypnagogic and hypnopompic? Or is it B, rapid eye movement and non-rapid eye movement? Or is it C, alpha and beta, D, delta and theta? The answer is B, REM and non-REM. So with normal sleep, it can be divided into two phases, the REM and the non-REM. Hypnagogic is the state of being awake and sleeping, whereas hypnopompic is a transition between sleeping and wakened states. With beta waves, those are associated with day-to-day wakefulness. During periods of relaxation, but while still awake, our brain waves become slower, increased in amplitude, and become more synchronous. These types of waves are what we call the alpha waves. The first stage of sleep is characterized by theta waves. During a normal night's sleep, a sleeper passes through theta waves of stages 1 and 2 to delta waves of stages 3 and 4. Delta waves are the slowest and highest amplitude brain waves. Question 7. Which sleep pattern stage diminishes as an effect of aging? Stage 1, Stage 2, Stage 3, or Stage 4? The answer is Stage 4. As we age, Stage 4 sleep diminishes. Many people older than 75 do not demonstrate any Stage 4 sleep patterns at all. Between 2 to 5% of sleep is in Stage 1. In Stage 2, that's about 50% of normal sleep time. Stage 3, that's that transitionary time between light sleep and deeper sleep. Question 8. Which disease is associated with insufficient sleep? Is it A, cancer, B, renal failure, C, an MI, or D, glaucoma? The answer is C, myocardial infarction. So individuals who sleep less than 5 hours at night have a 3-fold increased risk of heart attacks. Cancer, glaucoma, renal failure, those aren't associated with lack of sleep. Question 9. You're assessing a patient who is being evaluated in an outpatient clinic for complaints of back pain. The patient reports taking diphenhydramine for insomnia related to job stress. Which response would be most accurate? A. This medication should only be taken for about a week. B. This medication can cause nausea. C. The medication should not be taken after eating a high-fat meal. Or D. This is a herbal medication that has been around for hundreds of years. The answer is A. This medication should only be taken for 1 week. So antihistamines, particularly first-generation antihistamines like doxylamine or diphenhydramine, have sedative properties that may be used for short-term treatment for mild insomnia. They are common ingredients in most of the OTC sleep aids, but the thing is, tolerance develops after only 1 week of using these. So increasing the dose actually causes more restlessness and more irregular sleep patterns. It doesn't cause nausea though, and there's no restriction in terms of a high-fat meal, and it definitely is not an herbal medication. Question 10. Which drug would you choose has better efficacy, acceptability, and tolerance for the treatment of insomnia? Is it A, esopiclone, B, melatonin, C, Ramelteon, or D, zolpidem? The answer is A, esopiclone, also called Lunesta. So with this medication, it's used to treat insomnia as a hypnotic CNS depressant, so you can get to sleep faster and you'll stay asleep throughout the night. It's more effective than Ramelteon or zolpidem for long-term treatment. Melatonin and other non-licensed drugs showed no overall benefit in a systemic review. Although benzodiazepines are very effective in the acute treatment of insomnia, their tolerability and safety profiles were not favorable and can produce dependence, tolerance, and withdrawal effects. Question 11. Which is the best psychotherapeutic approach to use for generalized anxiety disorder in adults? Is it A, individual cognitive behavioral therapy, B, group CBT, C, interpersonal emotional processing therapy, or D, exposure-based therapies, treatments? The answer is individual CBT. Why? Because it best addresses the maladaptive patterns of thoughts and behaviors central to generalized anxiety disorder. Question 12. Of the following classes, agents, which has or have demonstrated safety and efficacy in long-term management of GAD? Is it A, GABA, benzodiazepines, B, SSRIs, C, gabapentin, or D, all of the above? The answer is SSRIs. There are some safety concerns and potential tolerance and dependence limits that limits the use of benzodiazepines for the treatment of acute anxiety symptoms. However, SSRIs, nope, they're considered first-line pharmacotherapy for GAD. Question 13. When considering CBT or pharmacotherapy in the treatment of GAD, which of the following statements is most accurate? Evidence suggests that the magnitude of benefits with pharmacotherapy for GAD is greater than associated with other anxiety disorders. Or is it studies demonstrate significant benefits of providing CBT in conjunction with pharmacotherapy? Or lastly, CBT requires a larger time commitment, but benefits are long-lasting. The answer is CBT requires a larger time commitment, but benefits are long-lasting. The thing with CBT is it typically needs about 16 weeks, but gives long-lasting benefits. Although the benefits of pharmacotherapy are more rapid than CBT, evidence suggests that the magnitude of benefit is lower for persons with GAD. There is no evidence that combined CBT with pharmacotherapy offers any advantage. Question 14. Which of the following interventions by the PMHNP for a new person experiencing attaque de nervos demonstrates culturally informed care? A. Offering brief supportive psychotherapy. B. Offering a brief hospitalization. C. Requesting a family member act as an interpreter. Or D. Offering a low-dose, short-term anxiolytic medication. The answer is A. Offer a brief supportive psychotherapy. The literature suggests that although short-term and anxiolytic medications may be offered in an emergency room setting, attaque de nervos is best treated by a brief supportive therapy by a Spanish-speaking Latino therapist. Question 15. What is true about pharmacological treatment of anxiety in older adults? Is it A. Course of treatment is generally shorter than for younger adults. B. Drugs that are highly oxidized are more unpredictable than drugs that are mostly conjugated. C. The therapeutic dose of SSRIs is generally lower for younger adults. Or D. Highly lipophilic drugs have a more linear elimination in older adults. It's a great question. The answer is B. The drugs are highly oxidized are more unpredictable than drugs that are mostly conjugated. Why? Liver enzymes. Liver enzymes functioning, among other things, diminish as we age. So all the other statements would be false. Question 16. SSRIs like fluoxetine should not be prescribed for anxiety when the patient is also taking which medication? Is it A. Linelozid, B. Simvastatin, C. Levothyroxine, or D. Gabapentin? The answer is A. Linezolid. So the thing with linezolid is that it is used to treat certain infections and may actually increase serotonin as a result of the monoamide oxidase A inhibition. Thus, its use is contraindicated in patients taking fluoxetine. If linezolid must be administered, you have to discontinue the fluoxetine or any other serotonergic drug immediately and monitor for CNS toxicity. Serotonergic therapy may be resumed 24 hours after the last dose of the linezolid dose or after 5 weeks of monitoring, whichever comes first. Question 17. Your patient is in a state of hypnosis, which means the patient is in what state? A state of extreme sedation in which the person no longer senses or reacts to incoming stimuli. B. A state of tranquility in which the person can be made to do whatever is suggested by others. C. A feeling of tension, nervousness, apprehension, or fear with high levels of awareness. Or is it D. A state in which the brain is no longer sending out signals to the body? The answer is A. A state of sedation in which the person no longer senses or reacts to incoming stimuli. So with hypnosis, this is an extreme state of sedation in which the person no longer senses or reacts to incoming stimuli. A state of tranquility, well, that's produced through minor tranquilizers by decreased anxiety. Anxiety is a feeling of tension, nervousness, and apprehension or fear. Sedation is a loss of awareness and reaction to environmental stimuli, which may lead to drowsiness. The state of suggestibility, though, that's often seen in television programs and is not an appropriate definition of hypnosis. If the brain stops sending signals, the patient would stop breathing and death would occur. Question 18. You're treating a 4-year-old child with a barbiturate. What is a common adverse effect of this that you need to assess for? A. Decrease in respiration. B. Vomiting. C. Excitability. Or D. Dry mucous membranes. The answer is C. Excitability. The barbiturates, being an older drug, they have established pediatric doses. These drugs must be used in caution, though, because of its often unexpected responses. Children must be monitored very closely for CNS depression and excitability. The most common adverse effects are related to the general CNS depression. Other CNS effects may include drowsiness, somnolence, lethargy, ataxia, vertigo, a feeling of hungover, thinking abnormalities, paradoxical excitement, anxiety, and hallucinations. Alterations in respiration and dried mucous membranes, they're adverse effects of antihistamines, which can be given to calm children down or induce sleep. Vomiting, well, that could occur with the use of peraldehyde due to unpleasant taste and odor of the drug. Question 19. You're discussing the use of alprazolam with a 68-year-old patient. What statement indicates that the patient has an understanding of the drug? A. When I stop having panic attacks, I can also stop the drug. B. This drug will calm me down in about 30 minutes after I take it. C. One dose will keep me calm for about 24 hours. D. I am taking an increased dose because of my age. The answer is B. This drug will calm me down in about 30 minutes after I take it. So the onset of alprazolam, it's about 30 minutes. The drug can be tapered after, not even can, it must be tapered after long-term use, and the duration is approximately 4 to 6 hours. With elderly patients, you want to give them a reduced dose. Question 20. What anxiolytic drug would be given to a premenopausal patient who is a registered nurse, planned to return to work at the hospital after anxiety is controlled? Is it alprazolam, diazepam, buspirone, or transine? The answer is buspirone. So buspirone, it's a newer anxiolytic drug that does not cause sedation or muscle relaxation. It is preferred when the patient needs to be alert, such as when driving or working. Alprazolam, diazepam, and chlordiazepate are benzodiazepines, which cause drowsiness, sedation, depression, lethargy, confusion, and decreased mental alertness. It would be unsafe for a nurse to function in her whole role while taking any one of those drugs. Question 21. A patient arrives at the ER after attempting suicide by taking an entire bottle of diazepam. What's the antidote that you'll order? Phenobarbital, Precedex, flumazenil, or Ramelteon? The answer is flumazenil. Why? Is because that is the antidote for benzodiazepine overdose, and it's administered to reverse the effects of the benzodiazepine when used for anesthesia. Phenobarbital, a barbiturate, would further depress the body's function of this patient. The others, it's not going to work either. One's a hypnotic drug, and the other also, again, hypnotic. So adverse effects of these drugs include depression and suicidal ideation. Question 22. An elderly patient has been taking Ambien as a sleep aid for the past 2 months. On admission to assisted living facility, it's determined that the drug is no longer needed. What should you be concerned with? A. Hallucinations. Those are common. D. The drug will need to be withdrawn gradually. C. Another anxiolytic will need to substitute for the Ambien. Or D. Sundowning is a common withdrawal symptom from this drug. The answer is B. The drug needs to be withdrawn gradually. It is so important for the nurse to understand that zolpidem must be withdrawn gradually over a 2-week period after prolonged use. If chloral hydrate is suddenly stopped, it will result in a serious adverse effect. Hallucinations and sundowning, that's not common with withdrawal of this drug. So the prescriber and the patient would need to determine the need for the med and to substitute it for another anxiolytic. Question 23. Why would you expect the patient with liver disease to receive a smaller dose of benzodiazepine? Is it A, excretion of the drug relies on liver function? B, the drug is metabolized extensively in the liver? C, they are lipid soluble and well distributed throughout the body? Or D, the drugs are well absorbed from the GI tract? The answer is B. The drug is well absorbed from the GI tract. So with benzodiazepine, they're metabolized extensively in the liver. Patients with liver disease must receive a smaller dose and be monitored closely. Excretion is primarily through the urine, and all the other answers are true, but the only fact that is the benzodiazepines are metabolized in the liver explains why the patient with liver disease would require a smaller dose. Question 24. When compared with benzodiazepine, buspirone stands out as unique among anti-anxiety medications because of what factor? A. Increases the CNS depression of alcohol and other drugs. B. Lacks muscle relaxant and anticonvulsant effects. C. Causes significant physical and physiological dependence. Or D. Rapidly absorbed from the GI tract and metabolized in the liver. B. It lacks muscle relaxant and anticonvulsant effects. Buspirone is that newer anti-anxiety agent and has no sedative, no anticonvulsant, or any muscle relaxant properties, and its mechanism of action, well, it's unknown. However, it does reduce the signs and symptoms of anxiety without the many CNS effects and severe adverse effects associated with other anxiolytic drugs. Most of the anti-anxiety drugs are rapidly absorbed from the GI tract, metabolized in the liver, and have significant drug-drug interactions with alcohol and other drugs, and can result in psychological dependence. Question 25. Your patient said that they stopped their benzodiazepines abruptly. Oh gosh, what should you assess for? Is it A, urinary retention and change in sexual functioning? B, dry mouth, constipation, nausea, and vomiting? Or is it C, nausea, headache, vertigo, malaise, and nightmares? Or D, in most cases, nothing significant would happen. The answer is C. Abrupt cessation of these drugs may lead to withdrawal syndrome characterized by nausea, headache, vertigo, malaise, and nightmares. When benzodiazepines are stopped abruptly, the likelihood of withdrawal symptoms increases with the length of time the patient had been taking the medication. Urinary retention, change in sexual function, dry mouth, constipation, nausea, vomiting. All those are adverse effects of the medication classified as benzodiazepines. We're almost there. Question 26. A 78-year-old female is brought to the emergency department by her daughter, who notices that her mom is complaining of confusion, like seizures, and abnormal perception of movement. You are reviewing the medication bottles and you suspect the patient overdosed on what medication? Is it A, benzodiazepine, B, antihypertensive, C, sedatives, or D, analgesics? The answer is A, benzodiazepine. A common manifestation of benzodiazepine toxicity does include anxiety, psychomotor agitation, insomnia, irritability, headaches, tremor, and palpitations. Less common but more serious manifestations include confusion, abnormal perception of movement, depersonalization, psychosis, and seizure. These symptoms are not found in the associated options of B, C, or D. Question 27. Hypnotic drugs are used to aid people in falling asleep. What physiological symptom does a hypnotic act on to be effective in helping a patient sleep? Is it A, limbic system, B, sympathetic nervous system, D, lymph system, or C, the RES? The answer is reticular activating system, the ARES. Hypnotics, well, they're used to help people fall asleep by causing sedation. Drugs that are effective, hypnotics, act on the reticular activating system and blocks the brain's response to incoming stimuli. Hypnosis, therefore, is an extreme state of sedation in which the person is no longer sensing or reacting to incoming stimuli. The other option, they just aren't correct. Question 28. A patient presents at the emergency department with respiratory depression and excessive sedation. The family tells you that the patient has been taking medication throughout the evening and hands you an almost empty bottle of benzodiazepine. What are the other adverse effects you should assess for with this patient? Seizures, tachycardia, headache, or coma? I hope you picked coma. That's the right answer. The toxic effects of benzodiazepines include excessive sedation, respiratory depression, and coma. Flumazenil is the specific antidote that competes with benzodiazepines for benzodiazepine receptors and reverses this toxicity. The other things like seizure, tachycardia, headache, would not normally be associated with the benzodiazepine toxicity. Question 29. Your elderly patient is taking a benzo. Caution should be used in this population because of what possible adverse effect? A, acute renal failure, B, unpredictable reaction, C, paranoia, or D, hallucinations? It's the unpredictable reactions. The use of benzodiazepines should be done with caution in elderly or debilitating patients because of the possibility of unpredictable reactions and in patients with renal or hepatic dysfunction as well, which may alter the metabolism and excretion of these drugs, resulting in direct toxicity. So dosage adjustments usually are needed in such population. Acute renal failure, paranoia, hallucinations, they're not really common and related to the therapy with these medications for the elderly to be concerned with. Question 30. You are ordering a barbiturate medication for a patient. What adverse effects should you teach the patient about? A, double vision, B, paranoia, C, tinnitus, or D, thinking abnormalities? Did you get this one? The answer is D, thinking abnormalities. The most common adverse effects are related to general CNS depression. CNS effects may include drowsiness, somnolence, lethargy, ataxia, vertigo, a resemblance of a hangover, thinking abnormalities, paradoxical excitement, anxiety, and hallucinations. Barbiturates drugs typically do not cause double vision, paranoia, or tinnitus, though. Almost done. Question 31. A contraindication for prescribing a sedative hypnotic is having what listed in the patient's medical history? Neurological disease, liver failure, endocrine disorder, or heart disease? Liver failure. So with benzodiazepine, they undergo extensive hepatic metabolism, In the presence of liver disease, the metabolism of most benzodiazepines is slowed, with resultant accumulation and increased risk for adverse effects. The neurological disorder, endocrine disorders, and heart disease, they're not contraindications for use of benzodiazepines. Question 32. Which sleep pattern stages diminishes an effect of agent? Stage 1, Stage 2, Stage 3, or Stage 4? Did you get it? It's Stage 4. As we age, Stage 4 sleep diminishes. Many people over the age of 75 do not even demonstrate any Stage 4 sleep patterns. Between 2 to 5% of people that they sleep, they're in Stage 1. In Stage 2, that's about 50% of normal sleep time. And Stage 3, that's that transitionary time between lighter sleep and deep sleep. All right, got a question 33. You have a 19-year-old patient who suffers from panic attacks and asks the GP, the PCP, if there is any medication that he could take for his condition. Which of the following medication is most likely suitable for a first-line choice of treating panic disorder? A. Lorazepam, D. Diazepam, C. Buspirone, or D. Paroxetine. The answer is D. Paroxetine. SSRI is licensed for panic disorders such as paroxetine and should be first-line choice if pharmacological management is chosen. The others, they are suggested as second line if there's an inadequate response in 12 weeks. But benzodiazepines like the lorazepam, diazepam, like an example above, or buspirone, those are and sedating antihistamines have no place at all in managing panic disorders. CBT or drug treatment is recommended. SSRIs are first line. If contraindicated or there's no response in 12 weeks, then you can use ipramimine or clopramine. All right, last question. Question 34. So you're working in a psychiatry unit. You're taking a history from a patient with a new diagnosis of GAD. You take a thorough past history. Which of the following is a risk factor for a GAD development? Is it A, being under 20 years of age? B, have an AFib? C, being recently divorced or separated? D, having hyperthyroid disease? The answer is being recently divorced or separated. So let's first look. What are the risk factors for development of GAD? They are age 35 to 54, being divorced or separated, living alone, being a lone parent. What are protective factors? Protective factors are that age of 16 to 24 and being married or cohabiting with somebody. Having a hyperthyroid disease or AFib may result in symptoms that are similar to GAD, but it's not necessarily a risk factor. All right, congratulations. Thanks so much for studying with us. I really, really hope this is helpful for you and that you do well on your test. If you do find this helpful, please share this with your classmates so all you guys can succeed. If you don't mind, like and share this and subscribe. Thanks. See you at the next video.